And Dr. Mascarenhas, can you walk us through how PV is diagnosed?
First, maybe I'll set the stage. PV patients can show up from different avenues. Sometimes they show up to a hematologist's office because the primary doctor may have noticed a high platelet count, maybe a high red count, maybe a high white count. Sometimes they show up because they unfortunately had a thrombotic event and they were in the emergency room. And sometimes in women, it could be abdominal vein thrombosis. Sometimes it could be cerebral sinus vein thrombosis. Sometimes it could be more classic, like a heart attack or a stroke. So sometimes patients show up with more acute issues that get the attention of the medical community, and that could be in the ER, and then they're seen by hematologists in the hospital. Sometimes they're referred by primary docs because the primary docs see over time that the blood counts are going up. And sometimes they're referred for reasons that may not be specific to elevated blood counts. So sometimes patients are found on routine imaging for other reasons to have an enlarged spleen, or they have a lot of complaints of headaches, and they've seen a lot of headache specialists and neurologists, and then someone sort of starts to put it together. I've had very unusual things happen. Like I had a woman who presented with hemichorea, which is a movement disorder, and it was very unclear why. And she saw multiple neurologists, and then finally someone recognized, maybe the red count for this older lady is a little bit higher than one would expect, and that's how it got to my attention. So it really patients can really present and end up in hematologist's office for various reasons, and sometimes it's incidental findings on blood counts. And one thing about the MPNs, which I think most specialists would agree, is these are not a uniform group of patients. They're really heterogeneous and variable. Every patient comes with a sort of different story. There may be overlaps, but different and distinct stories, histories, and clinical courses.
Yeah, absolutely. When is a bone marrow biopsy needed, and really what does that show?
So I'm a hematologist that thinks that every patient with a myeloproliferative neoplasm or and suspected MPN should have a baseline bone marrow biopsy, and that even includes the patients with polycythemia vera. And the reason why I think that's important is because sometimes we're wrong, and they can have adjacent or overlapping diseases. There's often a higher risk for having second primary malignancies, what we call SPMs, where people can have lymphoid diseases like CLL, chronic lymphocytic leukemia, in the bone marrow as well, or what's called MGUS, monoclonal gammopathy of undetermined significance, or even multiple myeloma or lymphoma. So this is very well recognized, and one of the reasons why I also advocate for a bone marrow biopsy at the time of diagnosis, but also to get a sense of what grade of fibrosis do the patient have, because some patients actually have dense fibrosis even at the time of their diagnosis while it's still polycythemia vera, and that has some prognostic significance. It also allows one to get chromosomal analysis, next generation sequencing right from the source of the bone marrow. What I am not an advocate for is serial bone marrow biopsies. That's unnecessary. So I think a diagnostic bone marrow biopsy is due to every patient who has a suspected blood disease or blood cancer, and only repeating it in the setting of assessing response to a treatment or a change in clinical features that would warrant it, but not yearly bone marrow biopsies or anything of that nature.
Great, thank you. Another question we get a lot is, can you explain what the variant allele fraction or the VAF is for patients?
So the VAF is just a fancy way of saying amount. It is really a way of measuring how much mutation in a group of cells exists in the context of what's called wild type or non-mutated gene. So when we talk about the VAF, the variant allele fraction, what we're really saying is if we take cells from your peripheral blood and then get rid of the cell part and just get the DNA from all of those cells, and then look to see specifically how much JAK2 mutation is there in relationship to all of the JAK2 genes, both mutated and wild type. That gives us a general sense of the burden of disease, how much JAK2 mutated cell burden there is. Because in polycythemia vera and myeloproliferative neoplasms in general, we can't get an image, we can't measure a tumor like a breast cancer tumor or a lung tumor, but what we can do is measure the amount of disease in the body by measuring the JAK2 mutation. It's an indirect measurement of that disease burden.